name is Pangeran Akbar from Indonesia. I changed my title a little bit, dissection on CTO treated with DCB, friend or foe. As a background, CTO PCI has rapidly evolved. Despite major improvement on equipment and technique, the stand failure remain as high as 20% in long term. Management CTO with a long-standing require long-term DAPT, which will increase risk of bleeding. While PCI using DCB is gaining popularity, including CTO lesion, they give us several benefits, allowing native vessel to grow, shorter DAPT, avoid metallic complication, and induce positive remodeling. This is my first case of the 2 years old gentleman with underlying hypertension and CKD, history of non-STEMI 5 months ago, EF preserve. The thread is okay, LAD okay, the RCA distal is a simple CTO lesion. So we proceed to the PCI, the RCA with the BMW and Pilot 50, parallel wiring. It's not a complex CTO cases. Then we cross with the Pilot 50 with non-compliant balloon 2015, 30 seconds. Then we see the lesion preparation. Then we up again to the NC 3015 up to 60 seconds to proximal until distal RCA. And then I think it's an acceptable result for DCB. Then we put DCB 2030, 3040, 3040, and 3040, all DCB. And this is the result after DCB deployed. As you might see, there's a nasty dissection there, TB3 flow, but there's also in the proximal RCA contrast staining, so I believe that's a type C dissection. So would you leave it? If I leave it, I won't sleep well tonight, bowel stenting, prolonged blood inflation to touch up the dissection, or the end the procedure and relook. So I choose end the procedure and relook. 1 year surveillance, it's not clinical driven, patient asymptomatic, the vessels looks okay, and the dissection is healed. So this is the diagnostic after DCP, nasty dissections from proximal to mid RCA, and 1 year surveillance, patient asymptomatic, the vessel looks okay. Second case is 57 years old gentleman, hypertension, dyslipidemia, exertional chest pain, EF 40%, ECG shows signs rhythm with a T inversion on anterior leads. This is the diagnostics, Sturck's mild disease. We can see the proximal LAD CTO from the LAD proximal, the RCA giving collateral to the LAD. So we put PCI there, B300, 6 French, filler XT, cross the lesions, SC below 1.515. Then we pre-dilate more with the 2020, 30 seconds. We see there's a dissections on the mid to distal LAD. Then we upsize the balloon, 2.520, 30 seconds. Again, there's a dissection from proximal to distal LAD. But we see, we just put DCB there, 2035 distal LAD, 2.25 mid LAD, and 2.75, 20 proximal LAD. And again, nasty dissections. Would you leave it, infested, and relook, or just bowel stenting? Of course, it's ugly dissections. And I choose to leave it, infested, and relook. So this is diagnostic, CTO LAD after DCB deployment, and 1 year follow-up, patient asymptomatic. But unfortunately, 5 years from the index event, patient came to our hospital due to chest pain. The problem is on the RCA, not the LAD. The LAD still looks great. So why DCB in CTO? We know that vessel distal to a CTO are narrow because of absence of blood for a long time, no flow, no grow. After flow is restored, it takes several weeks or months for vessel to grow. The problem with DES may be is underestimate the vessel size, increasing the risk of standardizing, risk of restenosis and latent malposition. We know from the Asian Pacific consensus for DCB, type A and type B dissection are always been safe. Type C dissection are more open to debate. Type C dissection greater should be DES, but in our cases, there's a type C dissection on the proximal RCA. Since it's a CTO started with no flow, I just leave it and use DCB instead. So again, from another study from Japan, he concluded that in the no-flow coronary artery lesion that received DCB treatment, fracture associated with the target lesion failure were being on hemodialysis, the presence of severely calcified lesion, and the absence of post-PCI medial dissection. So from this study, we know that dissection is our friend in DCB, not our foe. So again, from the study from the South Korea, almost dissections completely healed. There was no newly developed dissection at 6 month angiography. So should we lower our threshold for dissection in CTO DCB approach? Because it started with no flow, already in the worst case scenario. Dissection is part of the job in the CTO business. We're talking about ADR, first card, we're talking about dissections. So the final question would be, dissection on CTO treated with DCB is friends or foe? In my personal opinion, is a friends with benefit, terms and condition apply. Conclusion, we report a case successfully treating CTO with DCB only. Decision preparation, of course, is important for DCB approach, and bad dissections are healed on the follow-up. Take-home message, full metal jacket become less metal jacket. Less doesn't necessarily mean worse. Sometimes less can be better. Just like this guy from the Olympic shooting game, he used a simple outfit compared to the opponent, very complex outfit, very complex goggle. He still won the case. Thank you.
Thank you very much.